So good morning, everyone. I'm Dániel, and let me introduce my PhD topic, which is artificial intelligence in oral medicine. I'm a prosthodontist and a Department of Oral Diagnostics, and also a first-year PhD student here at the CTM. My vision is to provide an artificial intelligence-based guidance for clinicians to help diagnose and treat oral medicine patients, and my mission is to verify artificial intelligence as a reliable support for clinicians, find the possibilities and the limitations of this technique. And to reach those, right now I have two specific goals, and let me introduce the first one, which is the investigation of the diagnostic accuracy of artificial intelligence in oral potentially malignant disorders, and it's going to be a systematic review and meta-analysis. About the background, oral cancer is an urgent problem nowadays because almost 400,000 new cases every year worldwide, and almost 200,000 deaths. This is the sixth most common cancer worldwide, and the 5-year survival rate is horrible. It's around 40%. It's because we diagnose those lesions in stage 3 and 4, but if we can diagnose those lesions earlier in stage 1 and 2, then the 5-year survival rate going to jump up to 80%. We also have to mention that someone going to lead to oral cancer, and what can lead to there is oral potentially malignant disorders, which can develop oral cancer in the future. And the worldwide prevalence of OPMDs is around 5%. Right now, there is an experience-based clinical diagnosis, and because there is a lack of experts, it's going to be cause diagnostic errors because the lack of accuracy, and we want to develop a new support, a tool to clinicians to diagnose those lesions earlier, and we're going to be able to save thousands of lives. So our aim is to investigate the diagnostic accuracy of artificial intelligence in oral potentially malignant disorders. Therefore, our clinical question is, what is the diagnostic performance of artificial intelligence in oral potentially malignant disorders? We used the PERT framework with the outcomes of OPMDs, with the primary outcomes of sensitivity, specificity, and accuracy, and secondary outcomes of F1 score and AUC. And we hypothesize that artificial intelligence can diagnose oral potentially malignant disorders with the same accuracy. We did our systematic search last year on 5 databases with the shown search key. At the beginning of the flowchart of selection, where we started with 12,000 articles, and we ended up with 7 eligible articles. As I mentioned, we have several outcomes. We already finished the analysis of sensitivity, specificity, and accuracy, and we are still working on 2 ongoing ones. Let me show our first forest plot. We describe the sensitivity and specificity. Let's talk about the sensitivity first. So sensitivity is the probability of the positive test if we investigating the disease population, and the specificity is the probability that we're going to have a negative test when we investigating the healthy population. As I mentioned, we have 7 eligible articles, but here we're able to see several rows, so more than 7. That's because almost most of the articles investigated not one type of AI, but more than one. And I also have to mention that we have an outlier in the first row, the Sharma article. We went after this. Why could it happen? Because the ResNet 50 is one of the most best performing artificial intelligence right now, and we find out that in this article they use the same teaching settings for all the architectures that can lead to this outlier in the sensitivity, because they didn't have enough data for this architecture to teach. At the end of the day, the overall sensitivity is of the artificial intelligence is 0.86 with the shown confidence intervals, and the specificity is 0.93. But we have to make context. We have to know what is the performance of the general practitioners and the experts of the field. That's why we have this table there, when we can see that the according to the sensitivity and specificity, the AI have the same performance as oral surgeon, and if we just concentrate on the sensitivity, it performs better than the general practitioners. In our second figure, this is the HSROC that contains the accuracy of the test. We can see the heterogeneity of the architectures, and also we able to see the outliers and the 0 point on the specificity side. About the strengths of our studies, that all of the pictures was biopsy proven. We have high amount of pictures in almost all the studies. The architectures are well described, and also the teaching settings are well described, but we have low number of studies which contains in the limitation parts. There are different amount of teaching pictures that can have influence on the outcomes, and also they use the same teaching settings within one study for the different architectures. As a preliminary conclusion, we can say that artificial intelligence can diagnose oral potentially malignant disorders with the same accuracy as expert, and has bigger sensitivity than general practitioners. On the clinical side, we can provide that we able to use these architectures for screening these lesions, and that's going to cause less burden in the special care. In the resource implication, we can say that would be nice if we can develop a biopsy-proven based OPMD picture database to develop new architectures, and also multi-class classification models would be better to use in the clinical side. Right now, we are at this great stage of the first project. And let me introduce the second one, which is the investigate of the diagnostic accuracy of artificial intelligence in oral lichen planus on histological images, and it's going to be an observational study. So, as I mentioned, oral potentially malignant disorders are the main reason of oral cancer development, and the biggest subclass of OPMDs is the oral lichen planus, which is a clinical pathological diagnosis. That means that we need the clinical features and also the pathological diagnosis. We have heterogeneous data about the malignant transformation of these lesions, but according to the meta-analysis, it's around 1.2%, but which is maybe a bit more important, that all these lesions have some can cause some trouble in the life of the patient, that's going to cause a decrease in the quality of life, and all those patients are treatable with the adequate therapy, but for the adequate therapy, we need a proper diagnosis. And we are humans, we make mistakes, therefore we try to provide a new tool to diagnose those lesions, because AI can make the same performance every time with no tiredness and no external influence factors. So therefore, our aim is to investigate the diagnostic accuracy of artificial intelligence on oral lichen planus in histological images. Our question is that what is the diagnostic performance of artificial intelligence in oral lichen planus on histological images? We use the PERT framework with similar outcomes just for now for oral lichen planus. And we hypothesize that artificial intelligence can diagnose oral lichen planus in a shorter time and with higher accuracy. And our clinical implication would be more accurate diagnosis. And how we would like to provide this study, we're going to gather samples from our data bank with the diagnosis of oral lichen planus and oral lichenoid lesions. Right now we have almost 300 of those slides. We're going to digitize those whole slide images. After that, the pathologist is going to re-evaluate all the slides. And after that, we're going to calculate the teaching, the validating, and the test samples, and also do the analysis with the AI. We find out this topic is feasible. So as a summary, right now we have 2 ongoing projects, both focusing on the artificial intelligence and mucosal lesions of the patient. And let me thank your attention with a quote of Albert Einstein: try not to become a man of success, but rather become a man of values. Thank you for your attention.
Regarding the first topic, how different were the disorder types between the studies? Were they all checking the same types, or how did you deal with that?
Mainly, they say that there are lots of subclasses within oral potentially malignant disorders. Almost the same has the same subclasses, but some of the studies are focusing on a special part of the OPMDs, so that can cause some heterogeneity in the data. But most of them uses 5 or 6 subclasses.
Could you subgroup them somehow, or not possible?
Not possible, because we have a few articles. We have one option, and we already did it, but I didn't have time to show you. We have subgrouped the analysis according to the number of the labels, the end labels, so the categories which the AI have to sort the lesions, and therefore were binary classifications and multi-class classification, and it seems like that still binary classification is better than multi-class classification. That's why in the research part implication I said that multi-class classification need to be developed in the future.
You mentioned these deep learning neural networks, but do you know anything about what the exact method is, how an AI system decides between 2 lesions, and why is it important that you validated it, or not you, but who did the measurement validated it with biopsy?
Yeah, so for the first part of the question, no one going to describe how these architecture define lesions. That's I think it's impossible to find in any paper. If we develop a new architecture, we're going to be able to find out that our architecture how works. But after testing and in papers, they won't describe it pretty well. And for the second part, that's this is the reason why we have low number of articles, because all the pictures in the inclusion criteria there were that all the pictures have to be biopsy proven, and there are more articles in the literature which have a boosted database with pictures gathered from the internet, but we exclude all those articles.
Okay, so maybe we could say that it's an evolutional algorithm because it develops with... Yep. Okay, yep. Thank you very much.
You mentioned these oral potentially malignant disorders, and can you please specify what are these?
Yes, sure. So it's a very diverse mucosal lesion of the mouth. There are lots of subgroups of it, and with very different clinical appearance. But the common of those lesions is all of those can provide to oral cancer. So they categorize like these lesions in the same class like this.
Did you perform the citation chaser for the first project?
Yes, we did. But we didn't find any eligible articles after the citation chasing.
I have one more question. Do you think it's possible to classify artificial intelligence models using the stage of learning regarding your project?
Yes, that would be nice, but there will be only one group, because all of those were convolutional neural network in the stage of deep learning.
Regarding the artificial intelligence, you mentioned that you have already 300 samples to teach the AI. Mm-hmm. What do you think, how many more do you need, and when is it completed? How could you decide that this sample size is enough for validation?
Thank you for your question. I'm pretty sure it won't be enough that we have right now, but it's going to be a multi-center study, and we're going to gather more samples from different universities, and therefore maybe we're going to get enough data to provide an AI and teach, validate, and test it. We don't know yet what's going to be the sample size for it, but we're still in the gathering stage, and we're going to gather as much information as is possible.